So, a little bit of an introduction to the Children's Hospital Alliance. We're a trust-funded alliance of 14 providers across the UK now, across England and Northern Ireland. So the network was brought together to help improve the quality, access and experience of children and young people in acute hospitals. The CHA's sort of mantra is to learn, lead and advocate for children and young people. So this network has been running for over a decade now to support children's health leaders and practitioners in coming together to improve everything pediatric. And one of the greatest strengths of the CHA is our sort of collective power as a member-run body. As we have a large cohort of patients, often with rare diseases in small numbers that are difficult for one trust to tackle alone. So a few stats for you. Our members across their catchment population provide care to around 3 million children and young people. This means they have around 4.5 million contacts with children and young people every year, accounting for nearly 25%, a quarter of children's hospital activity nationally, and with a total of around 2,300 pediatric general and acute beds, 286 of which are intensive care beds. Our members collectively hold 78% of England's intensive care beds for pediatrics. So why is data so important in pediatrics? Any of you that have worked in pediatrics or seen children and young people's data before will know sort of the challenges that the pediatric world faces with the availability of data and analytics. So traditionally it's been limited, although tools like NHS England's Speed It dashboard have increased the visibility sort of primarily around these surgical specialties. So historically, specialist children's hospitals have experienced poor data quality. Their data is often hidden within their trust's larger infrastructure and not specific for pediatrics. There is a lack of comparisons or opportunities to see comparisons with their direct peers, and pediatric data is hidden amongst the adult side of things as well. And often metrics are designed for adults by adults, so they're often inappropriate or non-applicable in the pediatric setting. So the problems I've just outlined have meant that children and young people have often been ignored in the national policy and reporting mechanisms. So the CHA's objective is to amplify their voices by using this rich pool of data to benchmark effectively. So this piece of work was commissioned by the CHA to inform their member trusts about the policy context and the practical implications of the government's 10-year plan ambition of the left shift. So from shifting activity from the community to, from the acute sector to the community. So to provide a realistic picture, we work to identify patients whose admissions may be classified as divertible, and I'll go into this a little bit later. So to do this, we used two primary data sources from our agreement with the Getting It Right First Time programme at NHS England. So this analysis only applied to our 13 English trusts. We used inpatient hospital episode statistics, so providing detailed patient level information on diagnoses, treatment that take place in an inpatient setting. And this was our sort of primary data set for this analysis. And then we also used the patient level information and costing system, otherwise known as PLIX, to show a record of precise activity and cost information for individual patient care and to assess the potential fiscal impact of the left shift for specialist children's hospitals. And we also used a publicly available data set, the general practice workforce statistics, to conduct some correlations between primary and secondary care. So to help us sort of get back in the headspace of September 2025, we've provided here a brief overview of the 10-year plan that was released in July 2025. And it focused around these three shifts. One from hospital to community, so the left shift, and the other two being analog to digital and sickness to prevention. So as I've said, this piece of work primarily focused on the left shift. And I particularly like this quote here, which summarizes the 10-year plan beautifully, that care should happen digitally by default in a patient's home if possible, in a neighbourhood health centre when needed, and in hospital where necessary. So a bit of background on the neighbourhood model. It was designed to integrate an acute hospital within the wider support system, including family hubs, schools, and nurseries. So specific initiatives included expanding mental health support teams in the community and in schools, developing young future hubs, and introducing the My Child digital record. So this service will be delivered by a neighbourhood multidisciplinary team made up of at least a GP, community paediatrician, and a mental health practitioner, so spanning primary, community, and the acute sector. And the original central commitment of the 10-year plan was that the funding will follow the patient from this acute setting into the community. So it's important to consider sort of the funding flows in this piece of work as well. So onto the analytics and understanding the impact of this left shift from the acute to the community. So what we did was that we tried to identify these potentially, and potentially is an important word here, divertible patients using three criteria. We looked at ambulatory care sensitive conditions, very short stays, and low clinical intensity non-elective admissions. So for ACSC conditions, we used academic definitions, and these typically include acute conditions like ENT infections and pneumonia, chronic conditions like asthma and epilepsy, and vaccine preventable conditions. Very short stays we defined as patients that stay less than 24 hours in hospital, which could indicate that their care could have taken place outside of an acute hospital setting. And low clinical intensity, so we use something called the Pediatric Appropriateness Evaluation Protocol, which is quite a mouthful. I'll just go into what that is. So it's a tool designed to assess the appropriateness of pediatric hospital admissions. So basically it evaluates the medical necessity of a child's stay in hospital. So we looked for any diagnosis that is high risk within their sort of diagnosis codes in the hospital episode statistics, and any procedure that is of high acuity. And we flagged these patients as clinically appropriate. Any patient without one of these either conditions or procedures is flagged as potentially inappropriate for being seen as in an inpatient setting. So we're very aware that sort of these three groups alone are not enough to identify what patients could be diverted from an acute setting to the community. So what we did was we cohorted these. So every single patient will either be in none of these buckets at all, one bucket, so the low confidence cohort, a moderate confidence cohort, so having two of these factors flagged, or a high confidence cohort, so where they are ACSC, short stay, and deemed as clinically inappropriate. So getting into sort of the actual analysis now, the volumes of divertible admissions, we found that 34% met this moderate confidence cohort threshold, so two or more criteria were flagged as potentially divertible, and then 7% of all admissions across our CHA trusts were in this high confidence cohort, so having an ACSC condition, non-clinically appropriate, and having a short stay in hospital as well. So in this analysis, we focus mainly on the high confidence cohort, as this is the sort of most accurate and reflects the safe and practical opportunities for diverting patients from the acute sector to the community. So here I've anonymized our CHA trusts on the left, so we can't see which trust these figures belong to, but you can see that there's considerable variation between providers for both the moderate and the high confidence variables. And here as well, just presented slightly differently, you can see this variation within the high confidence cohort. And the reasons behind this are sort of multifold. It could differ by trust due to the patient mix, so their complexity, or existing community and primary care provisions within their area, or maybe just sort of the demographics of their population. So the trust must consider all of these different things when considering their strategic positioning when diverting patients to the community. So we try to sort of pinpoint where divertible admissions sort of may be higher. So we started looking at demographic factors. We first looked at age. So of the high confidence cohort, we see that more divertible patients as a proportion of their total admissions appear in their younger years, so primarily in their primary school ages. And this may be due to sort of parental anxiety or a lack of known alternatives for these patients to go to, so they just present in the emergency non-elective setting. So this suggests that there are potentially relevant opportunities for trusts to explore to provide more support through these family hubs or within a primary school setting. We next explored diagnosis, and we saw that respiratory conditions, so these J codes here, are most primed for diversion. So we suggested that it could be beneficial to manage these conditions outside of an acute hospital, perhaps in a virtual ward, primary care education, or school support for conditions like asthma. And a particularly interesting thing here is R56 and G40 diagnosis codes on the left-hand side are both seizure related. So perhaps ensuring appropriate epilepsy management within the community could help divert some of these patients from sort of the high cost acute setting. And just harking back to the last slide, we looked into how this differs based on how old a patient is. So for 1 to 8-year-olds, the most common diagnosis are these upper and lower respiratory infections, whereas for 9 to 16-year-olds, they're sort of the asthma side of things, which account for nearly 1/5 of these high confidence divertible patients. So again, looking into how we can effectively manage asthma within the community to stop these potentially divertible acute admissions. Next, we looked into deprivation. We found that there was a weak but slight negative correlation that existed, meaning that patients from more deprived areas, so 1 being the most deprived here on this scale, are slightly more likely to have a higher level of divertible admissions than those from less deprived areas. So this is something that CHA trusts can specifically have in mind when moving activity from the acute setting to the community to make sure that none of their patient cohorts are left behind. However, when we looked into this in more detail, this was primarily driven by 2 CHA trusts. So when we removed these 2 CHA trusts, we actually found that there wasn't a strong relationship at all between deprivation and divertible admissions. So perhaps it's something for those two trusts to focus on a little bit more. We also explored whether there was a relationship between primary care capacity and the proportion of divertible admissions. So the theory behind this was if the primary care provision within a certain area was particularly good, then the levels of divertible admissions would go down. However, we found that there was a non-significant correlation for our CHA members here, meaning that that higher patients per GP does not correlate or correspond to a lower proportion of divertible admissions. We also looked at this slightly differently, looking at the infrastructure in particular areas, so GP practices per 100,000 patients, and similarly found that any correlation here was not significant. So just to recap on the potential drivers that may contribute to a higher volume of divertible admissions. We looked at demographic factors, age, which I've highlighted in this presentation, and sort of noticed that there was a variation here between age groups. We also looked at gender and ethnicity, which I haven't gone into in this presentation, but found that there was no significant difference in divertible admissions. We also looked at deprivation and found that there was a weak but significant correlation. Access to primary care seemed to have little to no effect on the levels of divertible admissions. But this sort of last bucket here is the wider context, the things that we didn't get to explore in this analysis, which is looking at the more qualitative side of things. So the type of services offered by a trust to the community already, the availability of alternative hospitals in the acute setting, coverage of services like health visiting, social care, sort of what the schools already offer, the in-school support, and other factors influencing local health behaviours. And finally, we looked at the potential costs of these divertible admissions. So here we used cost and activity data from the previous financial year, which was very comparable to the financial year that we were looking at. We did this because at the time of analysis, there was no patient level costing data available for the most recent financial year. So here we focused on variable costs, so basically everything excluding what it normally takes to run a hospital. So variable costs are sort of bloods, drugs, imaging that are conducted for each patient on their admission. And we found that there was £4.6 million spending across these 13.5 divertible admissions in the CHA. Nearly a £350 spend on average per divertible admissions. And again, kind of what we've highlighted before, this spend is different across different CHA trusts, with 4 of them spending over £500,000 each on admissions that may have been divertible. The most spent by a CHA trust as a percentage of their non-elective spending was 5%. So although these costs represent an opportunity to save money for CHA trusts, we must also remember that there is an operational challenge. So these costs we can treat as a proxy for income. So if the funding will follow the patient out of the hospital, trusts must look at this when supporting moving activity into the community and plan about how this loss of funding may affect them. So, in conclusion, this presentation has highlighted that nearly 14,000 non-elective admissions across the CHA per year could be diverted away from these acute settings and effectively managed with the community. This accounts for around 7% of the CHA's overall non-elective admissions. These are primarily respiratory conditions, and seizure-related conditions also feature prominently. £4.5 million was spent across the CHA on variable costs, nearly £350 on average. And not highlighted in this presentation, But in several workshops that we did with CHA members, we came up with strategies for managing some of these divertible conditions in the community, including empowering patients through education and technology, providing joint care with community providers and primary care providers, and training staff up in the community to deal with some of these more divertible conditions, and setting up virtual wards primarily run by secondary care providers that will keep patients out of the physical hospital setting. So a bit of advice here in the last paragraph. Each CHA trust should seek to build relationship within their all age providers, their provider collaboratives, and within their primary and community care colleagues to ensure that they can provide the expert input needed to manage these patients in the community, as well as having a say on the funding and commissioning decisions in a world where funds may flow from these integrated health organisations set out in the 10-year plan. And I'll take down my slides now and hand back to Rachel.
Thank you, Izaak. Thank you very much. That was very interesting, and it's very kind of the 10-year plan is obviously something that a lot of us are interested in and directly involved with the recommendations and so on that are in it. The strategy unit, for example, we're supporting the national neighbourhood health implementation programme. So there's lots of parallels with some of the things that you're trying to do, and in terms of diverting or mitigating is some of the is a phrase that we use as well. Some of the activity that may be happening currently in an acute setting, and thinking about the alternative ways that it could be either diverted or at least part of the episode may be done in a different way. So it's all very interesting and fascinating to me to see it from a slightly different perspective, slightly different angle as well, and certainly that focus on children. So we've had quite a few questions or comments in the chat, which I'll turn to in a sec because I'll share my screen. Some of them are more sort of detailed and probably relevant to certain parts of your presentation. So I might just dive in at some of the bigger questions that we've ended on. None of them are hard. And if we don't manage to get through them, we can certainly pick them up after. I hope you'll be up for that as well. So I'm going to share my screen now so I will see what people have said on Slido. So I've had a few people contributing here. I was interested first in this second one, this point here, which is about you mentioned workshops, but when the question here is when you presented your findings to clinicians at the trusts, did they agree that it would be possible, in fact, to manage these patients outside hospital? Because there's obviously there is what the evidence says, but it's also what the people who are actually seeing the children will be thinking in relation to what that's showing.
Yeah, I think that sort of when we presented these findings back, the clinicians agreed with the sort of theory behind it, but obviously there's always a caveat to theories that in practice, often there is not this level of community support and primary care support to manage these patients. So it's sort of a phased process. We need to establish that level of community support and then move patients out from acute settings to the community. It all can't be done immediately without sort of the support in place.
Absolutely, and sometimes that means sort of a bit of a period of being a parallel things happening at the same time in order for that sort of that transition to happen. Now that's obviously very important. You can't stop one thing without there being something very clearly in place. And sort of linked to that, but there's somebody has felt here that they don't think that the admitted acute asthma could be managed in the community, but again, some of the definitions, some of the patients, they probably can, but there may be somebody who has personal experience thinking there's absolutely no way that could have possibly happened, and from there maybe a professional experience that doesn't feel that would be likely.
Exactly on that. I was trying during the presentation to say potentially as much as possible, because we know
Yeah,
that
yeah.
in some cases the sort of admission is very clinically appropriate, and that's why we try to use these three sort of cohorts and see whether any sort of procedure or particular diagnosis code flagged as definitely needed to be seen within hospital. But yes, we recognise that not every single patient sort of highlighted in this presentation would have been appropriate for the community.
Yeah, it's very much this type of work is very much about sort of about the potential, isn't it? It's about it's a starting point. These are the types of admissions, the types of treatment, the conditions that could be potentially be done in a different way, but it's not saying, right, off you go. We're not doing that anymore. There are so many other characteristics. There's so many other factors to consider, and it will vary, between the different areas as well.
Yeah.
So I'm just thinking, what we've got plenty of time to work through some of these questions. So I could sort of shall I just read some out, and then we can see we're able to pick them up. So I'm gonna shoot back down to the first ones which were raised, and some of them which were raised were because they were relevant at the time that you were talking during the presentation. So the first one, the one down here, talks about, are there any existing specific national directives or mandates for which, and I can't actually see the other part of that question because I've got this thing in the way, and I should be able to move that, but I don't know how to. Something about moving data which can support it. Is there other data things? Does that make sense without me being able to see the question? Are there any existing specific national directives, mandates for which? Can you see the question, or is it me? He can't see either, can you?
No, there's a
Well, I'm going to move on. I shall move on. I shall not make up words which I cannot see. I am not a politician. I'm going to move on to this one. Actually, we've got lots of questions, and I can share that one with you afterwards. This question is, what data sources do you incorporate? So, do you incorporate primary care data, for example, or is it just acute data?
so it's a bit of a difficult one, because we have sort of data sharing agreements for our 13 English trusts, so we can access their secondary care data. But anytime we have to incorporate sort of primary care data, community care data, we're relying on the publicly available data, so it's a bit less granular, and we'll often link back to ICBs or local areas rather than a secondary care trust in particular.
Okay. So you do partially include in this data, but you have less access to it really because you don't have those DPIAs in place. And I think as soon as you start to again, we're finding this from the wider program, if you like, the wider neighbourhood implementation program. It's the relationship or the data sharing with the GP practices, the primary care networks and everything is always variable. I would say it's variable, and it can be quite challenging to get all that set up. And if you waited for everything to be perfect, you'd actually never you'd never be able to get anything done. Okay, so the next question here. So this is something to consider. So how do you anticipate this work will be affected by the changes coming to ICBs and NHSE? Is this something that you're factoring in, or are you just focusing on the task in hand?
So in reference to this work and the wider sort of CHA's work, we're very aware of the upcoming changes to ICBs and NHSE and the effect that has on sort of advocacy of this work and other work we're doing on specialized commissioning, for example. So a lot of the work done within ICBs locally and NHSE nationally is sort of conducted using existing relationships with particular
Okay.
people in particular sort of positions of power. So we're working to make sure that those still exist in whatever format those changes turn out to be in. So
Yeah.
it's something that we're trying to proactively manage, but obviously there is going to be some sort of effect when people change positions and new people who have maybe never really considered the problems that pediatric organizations face are in the same positions.
You probably said it at the beginning of the presentation, Isaac, but who kind of like commissioned the work? Who's sort of where did it? I know you say it came from the 10-year plan. It set out that some of these are important things to consider. But are there several other things as part of the 10-year plan that people were considering, and this was just one of the project areas? How did it sort of come about?
Yes, so this was the main sort of data-led piece of
Okay.
the Children's Hospital Alliance, and anything that any piece of work that the Children's Hospital Alliance conduct is agreed by its members beforehand at a program steering group, committee, or a clinical reference group. But we've also been doing work into sort of analog to digital, which is more sort of shared learning, where
Okay.
trusts can come and present maybe their AI initiatives when it comes to note taking, for example, to other trusts,
Okay.
and then sort of share successes, challenges of those implementations as well. It's a really good community of just sort of open conversations when it comes to shared learning.
Yeah, no, absolutely. Much like the Midlands Analyst Network, Isaac. Anyway, so
Exactly.
thank you. Okay, great. So there's a specific question here which may not have come up in your in the analysis that you did, but somebody's asking here, does the proportion of divertible admissions, does it correlate with the trust's 4-hour ED performance? Is there any sort of relationship between what happens in the ED department and their targets?
So we have actually done quite a deep analysis on 4-hour ED performance, but
Wow.
unfortunately not correlated it with the divertible admissions I
Ah,
presented in this presentation. So that actually might
ah,
be an interesting thing to explore.
ah.
Off the top of my head, I think the trust at the top of the proportion of divertible admissions table and sort of towards the lower end of 4-hour ED performance are not correlated, but take
Okay.
that with a pinch of salt, and perhaps I'll come back in the future and present
Okay.
that
But
correlation.
yeah, I can see what the theory behind that might be. Um, now this is a specific question to something which you were talking about, so you might recognise the 7%, but this is what is the number of patients that make up the 7% cohort? Does that something that you need to go back into the presentation for? We can move on to another question if that's difficult
No,
to
I've still got it in
answer.
front of me. So it was
Okay.
14,000 children and young people.
Okay, so 14,000. Excellent, thank you. Um, And here's another question. So, or it's actually following on, or is it trusts that just admit all patients to PAU rather um, than has a single front door assessing them in ED? So I don't actually. I'm sure the question is fine. I've probably confused you and everyone in the in the way that I've read it. Does that make sense to you? I,
Sort of, yes. And again, it's probably not a great answer, but everyone that works with sort of trust coded data knows that it's very much up to the trust whether they sort of treat this as an ED level attendance in terms of the PAU, or whether the PAU sits within their admitted
yeah.
patient care data
Okay.
sets. So again, it just depends on how each trust codes.
Okay. Uh, it's often down to coding, isn't it? Often down to coding. We've looked at that one, never looked at this one. So we had a couple of questions which were asked after I started at the top. So here's one. How can we adapt to our local neighbourhood health programme, which is something I mentioned, based on their experience? So any tips, please? So this is how can we? So these are the things that I'm really interested in, and I'm sure everybody else is as well. So we, as analysts, we generate the evidence. We do the very best we can with the data that we've got. We consider the problem, and our approach to is answering the problem. But when it comes to how do we put that into practice? What are the next steps? How can we turn this into something that has an impact? So this is sort of a tips on using that information. So you must have thought of that bit a little bit as well.
Yes, yeah, this came up quite frequently in our workshops, where we were trying
Right.
to figure out how to sort of put this into action. So a
Absolutely.
lot of it is sort of local sort of networks and
Okay.
making sure that the connection between the large acute and the maybe DGHs, the community providers, the primary care providers is strong, and there's sort of a local trust there, because historically, in some areas that trust hasn't been there, and
Yeah.
sort of organizations have worked in silos, and therefore maybe a little bit more difficult to adapt to a neighborhood health program.
Yeah.
Again, there are national groups now, as well as the CHA, that are doing these shared learning sessions on what works, what doesn't. So tapping
Okay.
into a particular area,
Mm-hmm.
and asking sort of how to implement a particular neighborhood health program in your area, and where, and sort of the pitfalls to avoid is another thing that Trust said was particularly helpful.
Mm-hmm.
And yes, in terms of the neighbourhood health groups, the Children's Hospital Alliance has their own group, but there is NHS England's neighbourhood health groups as well, that do have an adult focus, but do sort of talk about the paediatrics as well.
Okay. I was thinking there often is an adult focus, but a neighborhood is obviously, it should be everything. So I imagine the learning that happens for adults is sort of relevant, and certainly
Hmm.
that those relationships that you're talking about, that the trust developing neighborhoods are all about the working together in that different way as well. Okay, thank you. So there's a couple more. So a couple more points here. I think we've got a couple more minutes as well, so we've got time to go through these. So someone has suggested that admissions look cheap at £340 per average, and I'm wondering if that's like it's not the actual cost of an admission. Is that some sort of, what can you remind us what the calculation is there?
Yeah, so it's all of the variable costs. So
Yeah,
it's
okay.
basically all of the tests, the
Okay.
imaging, the
Yeah.
drugs that go into that admission. And remember, all these admissions
Yeah.
are less than 24 hours.
Yeah.
So this doesn't consider any of the estate costs, the staff costs,
Yeah. They're still
the
there.
ambulance ferrying to
Yeah.
and from.
Okay.
This is just sort of what happens to them in hospital, because we wanted to see sort of the spending that could actually be removed from hospitals,
Yeah.
rather than I don't know, staffing costs that may just be rediverted to somewhere else in the hospital.
I mean, there is that potential that staff could have that dual role. I mean, I know they've done it in other places. Of again, these things, it's that isn't the immediate response. So is it? You need to consider what those variable costs are,
Hmm.
and then think about those different ways of working, potentially to have the real difference. So to link to that, someone is saying here that it would be interesting to understand the cost per patient for care for patients that that are diverted. So this is a recognizing that it is a difficult return on investment, and of course it isn't just about the money either. It's there is if you're looking at the wider the impact, it's a societal impact, and the impact more broadly on the child, their family, the care, and everything. So there's a big picture out there, and then there's a very sort of computational sort of trying to work out what that return on investment is in terms of sort of finance, I suppose.
Yes, and yeah, we're very aware that when we say sort of these costs per patients will be diverted, that particularly within our member trusts, our sort of specialist children's hospitals, that these admissions will sort of be backfilled by other patients who are maybe on a waiting list, so it's not cost saved. It's for those patients that actually don't need to be in hospital, that those costs are going elsewhere to the community, which is often a cheaper place than an acute hospital.
And better for them most likely as well.
Exactly. Yes.
So it is interesting. So the same the things that you're talking about is, you know, we've been looking at in this the bigger picture of neighbourhood health. And it also relates, in fact, to the work that we've been doing to support the new hospital program as well, and the future design of hospitals, which will include sort of children's hospitals as well. So this is what you call divertible sort of admissions or activity, but like I sort of mentioned, we've been calling sort of potentially mitigable activity. We use all the words to just to cover ourselves, really. We're not saying you can, we're saying these are the opportunities. And I think this is some of the thing that you're describing as well. These are the its potential, these are the opportunities, these are the areas that you're most likely to find some alternative ways, some better ways for children and for them to be treated. So it's about that potential. Now I'm very keen to get back to a point so someone has very kindly retyped their question so I can see the words. So I absolutely have to ask this one next. So are there any existing specific national directives or mandates for which you can outline the left shift and data which can support it?
So yes, within the 10-year plan, obviously there was sort of quite a lot of guidance on the left shift, but less so for children and young people. So the CHA in particular has been working with NHS England to try and define sort of a neighbourhood model for children and young people alongside partners from RCPCH, for example. So using sort of data found in this presentation, as well as our experiences of our trusts, to sort of inform those national directives of the left shift and what a neighbourhood healthcare system would look like for children, because as we sort of touched upon earlier, most of the national pilots, most of the national guidance has been sort of framed around adults and particularly frail adults as well. So yeah, just making sure that the voice of children and young people is not sort of ignored during these conversations and amplified using data.
Yeah, no, that's very, very well said. I'm going to totally steal that one. So I haven't got time for any more questions. I will. There's a few more which have been raised, which are really interesting. I'm glad we've had time to sort of go through some of those in a bit more detail. And there's a lot more I could bring to this. I think for some of the other work that we're doing that I've touched on, but we just quite simply don't have time. That's okay. So I just before I close in a minute by letting people know what's coming up next, I would just like to thank you so much, Izaak, for sharing that with us today and for the time that you spent with us. Really do appreciate it, as does everybody else. So thank you very much for that. And I'll stop sharing my slider and I will just share with everybody here what is happening over the next few huddles. So as is in the title, coming up in the next few huddles. So our next huddle, I think, is That's the right date? Yeah, I actually put some dates on this time. So this is about back to our colleagues in the strategy unit who are sharing their journey to build an open source renal model to understand the future demand of CKD and KRT. And I think that is probably for adults. I don't know, but it could be children as well. I don't know. So that's with our strategy unit colleagues. That's Lucy Morgan and Ewan Hon. And then I have a gap. If anybody, I realise I thought I'd fill the 19th of March. If anybody on the call today would like to present at in 4 weeks' time, I'm about to spend a few minutes just to fill that gap. But if anybody would like to present their work, that'd be great on the 19th of March. So then we've got the understanding the latest deprivation data and why it matters for health, and that's with the Health Foundation. Into May now, we've got the journey to create the domestic abuse strategy. That's the implementation plan, and that's in the Isle of Wight. So that's going to be very, very interesting. Again, we haven't really covered community safety very much so far, so I'm really interested to see that. So we're going right into sort of a public health domain, very much linked with the community safety as well. So looking forward to that. And then we've got policy evaluation methods and examples. That's with Alex Bottle, who's a professor of medical statistics, I think, at the Imperial College London. And then back to the strategy unit, we're going to be learning more about R. More of us need to be learning more about R. And then we've got several other things as well coming up, which I don't have time to go into. And it's 12 o'clock, so I've done absolutely brilliantly today. I'm so pleased with myself. I've been going over the last few times, and it's all down to you, Izaak. So thank you, thank you again for your presentation. I'll pop the recording on the website if that's okay with you, and your slides as well, and I'll share with you the remaining questions that you're very eager to see and respond to, I'm sure. So thank you very much, and thank you everybody for coming, and I'll see you in 2 weeks. Okay.
Thank you, Rachel.
Bye bye.